Hi, good afternoon. My name is Dr. Faisal Masud and welcome to this special edition of DEBAKEY CV Live. Today we have a very interesting topic about ECMO during turbulent times. And for this very intriguing topic, I have an esteemed panel of panelists who are going to be discussing and talking about it. I'm going to start with an introduction first. And on my first side is Dr. Divina Tuazon. Dr. Divina Tuazon is a medical director for Cardiovascular ICU in the DEBAKEY Heart and Vascular Center. She's a critical care specialist. On her side is Dr. Thomas MacGillivray. Dr. MacGillivray is Jimmy F. Howell Endowed Chair in Cardiovascular Surgery and Chief of Cardiac Surgery and Thoracic Transplant at Houston Methodist DEBAKEY Heart and Vascular Center. Next to it is Dr. Erik Suarez. Dr. Suarez is the Surgical Director, Lung Transplant, J.C. Walter Transplant Center, and an Associate Director of Mechanical Circulatory Support at the DEBAKEY Heart and Vascular Center. As you know, with these very high people, we're going to have a very good dialogue and discussion. Before I request Dr. Tuazon to do her presentation, I would like the audience to be part of our conversation. We will look forward to your questions. We help to answer some of those things. In order to do that, you can join us by web. Go to pollev.com, enter DEBAKEY, respond to activity. And the other is you can join us by text. Text DEBAKEY to 37607 and text in your message. So again, this having you all part of the conversation dialogue is so crucial. So without further ado, I'm going to request Dr. Tuazon to really start giving us some information how the journey of ECMO has been this turbulent time, what has been the background of ECMO, how that ECMO placement, management, and everything has evolved during the last 1 year, and how do we see and get feedback from Dr. MacGillivray and Dr. Suarez, how do we see the future and where we. So stay tuned. Dr. Tuazon, you have the forum.
Thank you, Dr. Masud. So this has been a very controversial topic here in the medical center at the same time as nationwide and worldwide as well. You know, ECMO has been very much part of therapy in patients who are in ARDS. But of course, during this pandemic, it became much more of in demand. So our topic today will be ECMO therapy during turbulent times. I have no conflict of interest related to this presentation. ECMO, as you know, has been available to support ARDS since the 1970s. However, due to high complication rates, it has been very limited in terms of its use in the world. And also, they had very poor outcomes early on. However, subsequent years had shown advances in technology and the management have led to improvement in survival and therefore reduced complication rates, resulting in increased use of the ECMO for severe ARDS. However, even though the outcomes have improved, there has not been a rigorously designed randomized controlled trials that have demonstrated it to be used as a standard of care for management for ARDS. Therefore, at this time, it still remains a salvage therapy for most cases of ARDS after failure of optimized medical therapy. And I guess that is a key word, okay? It is after failure of optimized medical therapy. So the first successful use of ECMO as salvage therapy was in the 1970s. However, subsequent studies have showed in the 1979 that really has not affected survival. So that's why its use has not been really, had not improved since then. However, in the 2009 influenza A H1N1 pandemic, it has generated more interest simply because there are much more improved survival at that time. And so, during the MERS in the 2012 until the 2019, it has been proposed as rescue therapy for patients with severe ARDS. Now, in the Caesar trial in 2008, 2009, and this is when they had showed that referral to an ECMO center actually has improved outcomes in this patient. Now, it did not show an improvement or survival or outcomes at that time, and neither did the Eolia trial in 2018. Thus, again, proving that it has only used a salvage therapy in patients with ARDS. Now, this is the timeline of the use of the ECMO in patients in viral outbreaks. However, in the SARS, it has not been used that much in 2003, but however, it started to gain prominence in 2009, and even in 2012, even though there's only limited areas where the MERS had affected, limited countries where the MERS had affected them. But in 2019, if you had noticed, this 2019-2020, there's a lot more of the countries that had been affected and a lot more of the population that has been inflicted with this virus. So in the World Health Organization dashboard showed that as of actually 2 days ago, there's 194 million cases, confirmed cases, and 4 million deaths. Of those, 34 million is in the United States and 605,000 deaths as well. Therefore, refractory ARDS with severe hypoxemia hypercarbia in COVID-19 has prompted the use of ECMO therapy, even though the benefit of ECMO for this population has not been proven yet. In March 2020, the World Health Organization had published interim guidelines recommending the use of ECMO in patients with severe ARDS secondary to COVID-19. And as of 2 days ago, there had been 6,895 cases that had been placed on ECMO worldwide that had been registered with ELSO, and with a 48% in-hospital mortality, which actually had worsened over time, but only a little bit. So the initial ELSO guidance in 2020, they had recommended early ECMO as per the Eolia trial criteria because they thought it might be this might be preferable to not initiating patients initiating ECMO in this patient population. So there is a lot of use of the ECMO at that time. However, they have noticed, like what I said, the mortality had increased. So in December 2020, the NIH had said that there's insufficient data to recommend either for or against the use of ECMO in patients with COVID-19. And this actually was shown also in the ELSO findings. The one that was published in October 2020, the orange the orange level had shown that there's actually patients who have been discharged home, and the pink one is the one that I meant in the top part of the slide. The pink one is the mortality. However, at the bottom part of the slide, it shows that the red one, which is mortality, has increased already, and this is as of July 2021. And then the orange one, which are the patients that have been discharged home, also had decreased. And if you notice, the green one, which is the hospitalized patients, have also increased. So the patients are staying longer in the hospital when they are placed on ECMO. So ELSO had updated their 2021 guidelines. Now they're saying that yes, definitely the run times are much longer and the overall mortality is also increasing. But they also recommended the conventional selection criteria should be used for COVID-19 related ECMO. However, there should be more stringent contraindications, mainly because of the constrained resources during a pandemic. And also they recommended formation of regional ECMO referral centers to facilitate communication, resource sharing, and expedited patient referral, and as well as mobile ECMO retrieval. Now there's a recent article that has been released in June of 2021. And this is actually a systematic review and meta-analysis showing that in-hospital mortality is actually similar in patients with non-COVID-19 related ARDS with COVID-19 ARDS patients. However, they've noticed also the increasing age is a risk factor for death. And so therefore, VV ECMO can be effective intervention in selected, quote-unquote, selected patients with COVID-19 related ARDS. Now, this is a 6-month mortality also published in June 2021, comparing COVID-19 to non-COVID-19 viral pneumonitis, showing the survival significantly higher in COVID-19 simply because there's a lot more of patients that have received several therapy because of the need to find treatment for them. Now, these patients also have increased MERS score, decreased burden of organ dysfunction, so the SOFA scores are much less. But there's increased incidence of pulmonary embolism, and there are longer run times. So, of course, what is needed during a pandemic is planning. So we have to be prepared to deploy ECMO on these patients, and knowing that there are unique challenges related to this, and that therefore the recommendation is to use ECMO only in specialized centers, and there should be judicious resource allocation, and we need to practice strict infection control measures. And it also highlights the importance of ensuring systems to enable safe and coordinated movement of critically ill patients, staff, and equipment to improve ECMO access. Now, this says the same thing, that the staff, as well as the equipment, the resources, the ECMO bed, all have to be coordinated well in preparation for ECMO therapy during a pandemic. So ELSO actually had released their renewed guidelines criteria for putting patients on ECMO. So the patients need to be placed on prone therapy and had to be optimized ventilation, as well as Flowland when the PF ratio drops to less than 150, which is ARDS criteria. However, the ECMO will be placed on patients who have a PF ratio of less than 80 or with a high PCO2. So let me show you our HMH experience. We have actually used our own inclusion and exclusion criteria. Apologize for the spelling of the criteria. I was in a hurry, so these are the same thing, but the one thing we have changed now is from the original CSAR trial, the MERS score is the one that is used, but during this pandemic, we have also used the PF ratio of less than 80. In terms of the exclusion criteria, again, apologize for the spelling. So the main thing that we have changed here is mainly because of the data showing that there's increased mortality with advanced age. We included the age of more than 65 as an absolute contraindication. And knowing that the SOFA scores are lower in COVID-19 patients, the SOFA score actually is now down to a relative contraindication. And you will see later on that patients who are ventilated for more than 7 days and those who have been 2 weeks of COVID symptoms actually have poor survival, so that also we're accounting for. Now, our absolute contraindication in this, our relative contraindication in this hospital is obesity with BMI of more than 50. But you will see in our next slides that actually they do not have that poor of survival with higher BMI, but not necessarily more than 50. So we actually have come up with a guideline for physicians to when to consult us for ECMO. So patients should be proned and on Flowland before they start. They call us unless there's a contraindication or if the patient is not able to tolerate proning. So they call us, and then the ECMO team is notified, and then we put the patient either in ECMO watch or we start the process of cannulating patients if they meet criteria. And then this is how, just to show you how the ECMO management is, by CV surgeons, by intensivists, by ECMO specialists, bedside nurses, and also the critical care physicians in that particular unit. After that, we actually have also created this ECMO acceptance process, as you will, because recently we have much more patients who have been calling us from outside of our system. So this acceptance process starts with transfer center being called, and then either from in-hospital, outside hospital, the intensivist is notified, and then we call the ECMO team, which actually is Dr. Suarez, Dr. MacGillivray, Dr. Masud, myself, and the rest of the CV intensivists, and then the case is discussed, and then if the patient is accepted or denied, transfer center will be notified. And after that, the next thing we have to look into is ECMO capacity. If we have the capacity, then the patient will choose the ICU where the patient will go, and then we will start the transfer process. If we do not have ECMO capacity, then the patient can be placed on an ECMO watch, or the physicians at the hospital where the patient is can cannulate the patient while awaiting for a bed to be available here in HMH. We also have this intake form that we have created for the outside physicians to fill out, or to at least be ready to discuss with us when they are going to call us for ECMO evaluation. Now, this is the family algorithm process. It actually starts before the patient is cannulated. We talk to the family members and let them know what they're going to be up against, and as well as they know what is the process when the patient is placed on ECMO. We also have a certain form that we're going to send to the family members, so at least they understand further in writing what is ECMO. And then after that, there's going to be constant communication between the CV surgeon, the intensivist, the ECMO specialist, the nurses, and the critical care physicians, as well as palliative care and ethics. It is very important that palliative care and ethic consultants are on the case when the patient is placed on ECMO. It helps with family members as well, talking who are not the physicians taking care of the patients themselves, but at least to help them guide through the process of their loved ones being on ECMO. And then after that, if the patient has stayed in ECMO for several weeks, and if the patient is improving, then we will continue the process. But if not, then we'll have to start the discussion of whether the patient is still benefiting from ECMO, or if the ECMO needs to be removed with that. Now, in HMH, since March 2020 till July 21, 2021, there are like 32,000 patients in the system. And this is like encounter, so patients can come back to the hospital, but there are only 17,000 patients, and they would have 9.5% mortality. And if you notice in the bars, it looks like there are only 2 waves in the bars, even as compared to we thought there are like 3 or 4. There's like a small wave, if you notice, in the beginning in March, but the big one is actually in July, and the next big one was in December. And these are demographics. Only 18% of the patients actually were admitted in the ICU, and 11% were ventilated. Now, when the patients enter the ICU, 3,000 of those patients were admitted in the ICU, and these are all hospitals. The mortality increases to 31%. So just being admitted to the ICU makes them, has a high predisposition of dying when you have COVID-19. And even with this one, you'll notice that these are all ICU patients too in the whole hospital. And so if you notice, like, the age actually is a major factor. When they're like more than 60 years old, they now have a 43% mortality. Of all those patients, there's a very small amount of patients who underwent ECMO. For all patients in the entire system, there's only 0.04% who underwent ECMO, and for all ICU patients, there's only 2.5% who underwent ECMO placement. So here, since March 2020 till July 2021, we have a total of 92 patients. 2 of the patients on ECMO are still awaiting lung transplant, and 5 had been decannulated but remains in the hospital. So the total number that you will see is only 85 here. Those have been discharged. And so 55 had survived and 30 had expired. That makes it 35% mortality in our hospital. in our HMH system, I meant. And by ECMO mode, most of them had been on VV ECMO. And this is just to show you that the ventilator settings had been optimized. So the patient had been majority of them had been on 100%, had been on high PEEP, mostly closer to 20, had a PF ratio of less than 75, and the Flowland had been used on majority of them. And patients had undergone prone positioning prior to ECMO cannulation. In terms of age, if you'll notice too, more than 60 is when they have increased mortality. So that's why we also have changed our criteria to absolute contraindication of more than 65. And here you will see in this slide that the higher the BMI, actually, surprisingly, they have a higher outcome. I think it's because of their nutritional status coming in, especially with the patients being hypercatabolic with COVID-19. Now, with those who underwent CRT pre or during the ECMO run, the patients have a higher mortality when they, have better outcomes when they're not on CRT. And again, in terms of time between intubation and ECMO cannulation, they have better outcomes if they're only intubated for less than a week. And then if they had been admitted for less than 2 weeks between admission and ECMO cannulation, and also between admission and intubation, they have better outcomes if they're intubated for less than a week. And if you'll notice, they do have longer run times, but it does not have any effect on their mortality, if you'll notice. Now, in terms of discharge disposition, there's 30 who have expired, and patients have majority have gone to LTAC, others rehab, home, hospital, or inpatient rehab. In terms of our transplant outcomes, there are only 11 who underwent lung transplantation of ECMO from October 2020 to July 2021. That's only 12% of the COVID ECMO patients. And also there are 2 COVID positive patients who developed ILD and who underwent lung transplantation but without ECMO. So now the question is, now we know that we can, but should we use ECMO for severe COVID-19 or any pandemic? Now, does the evidence suffice? When is it justified and when is it unjustified? So this article showed that when it's justified is mainly when we have the resources, we use the conventional intensive care measures, we filter out the patients and select them carefully, we allocate the resources, we continue to use them, and then we have to contribute to research to know which one works. So the question now is, when is it unjustified? The use of ECMO in the pandemic follows a U-shaped curve. When there's more patients, of course, there's more ECMO use. However, when there's a surge and then the system is saturated, then of course there's less use of the ECMO. And there even will come a point that there will not be any ECMO use on these patients because of the system becomes too stressed. And then if there's less patients, then either we have more patients who will be on ECMO or less patients on ECMO. So the moral of the story is actually the use of ECMO should not be considered in a vacuum. The consequences of choosing to initiate ECMO in a crisis are not just borne by that patient alone, but also with capacity and resources. In September of 2020, there has been this ethical algorithm that was published to ration life-sustaining treatment during the COVID-19 pandemic. If you notice in New York, they're so inundated that there are some patients who cannot be ventilated already at that time. But the question is, should we also ration ECMO during the COVID-19 pandemic? The point is we need to transition between standards of care during an acute crisis. We need to extend available resources effectively and efficiently, and we need to continue these efforts until we return to a previous step. So there are times that the use of ECMO will actually be the same, or it will have to be reduced, or it'll have to be increased, depending on when we transition to that standard of care. Now, when we allocate ECMO, since the ECMO is relatively late in use in ARDS, so it's still considered to be only useful in a subset of patients with the most severe form, and it is not regarded as a right equal to access to mechanical ventilation. And so when the volumes of the patients increase and we transition from standards of care to contingency and to crisis, sometimes the changes in ECMO technology in itself, the capacity, the resources, and the staffing will alter the balance of whether or not we switch from just contingency or straight to crisis mode. And so we noticed too during the COVID-19 pandemic, the crisis standard of identifying them is actually very dynamic. So you don't know when you cross that threshold. And so the different resources will be constrained at different points of time. So we have to carefully assess. We have to add resources if we need to, but we also need to think about the effect on other patients of choosing to offer ECMO to a specific patient in this environment. And again, the effectiveness of delivering critical care when the systems are under stress gets very much affected. There are two types of guidance that we use. Professional, which is from the organization like ELSO, when they said that when the resources are limited, then the youngest patients are actually of priority. And those who are severe CNS or with significant comorbidities, they suggest that it be excluded. And also there's discussion of termination of ECMO treatment when it is futile. Now this is the algorithm that they have said. The first one that they have noticed, they didn't even mention do not consider ECMO, but this one specifically, you'll notice in the top in blue, it did say when the resources are constrained, then do not choose ECMO, do not consider ECMO. The other guidance is for ethical standpoint, wherein patients may choose not to, or we do on a first come, first served basis. But if the sources are constrained, then we go for save the most lives instead of the first come, first served basis. Now, what do we consider when we are allocating ECMO during a pandemic? What the factors that we look at are the ones that are relevant to maximizing the benefit of ECMO treatment, meaning what is the chance of survival, what is the duration of survival, what is the age, and the quality of life post-ECMO. And the next thing we have to think about is capacity. And capacity is not just a bed, right? And so ECMO capacity means the machine, the number of beds, the ECMO staff, the surgeon, the intensivist, the nurse, and the specialist. Because when the patients enter the system, we don't have to account for the capacity for that one day or one night. We have to consider the capacity for so many days or weeks or months that the patient will be with us while they're in ECMO. And so we have to think about the duration of ECMO treatment. And we sometimes think about whether the patient is a healthcare worker who had contracted COVID while taking care of another patient who's inflicted with COVID. And also we need to think about the potential benefit of ECMO to other patients when considering discontinuing ECMO from a current patient with a low chance of survival if all of the ECMO circuits or machines were used, and if there's a good candidate patient or younger candidate patient who was referred for ECMO. So in terms of long-term recovery of these patients, the question is whether they will return to baseline, which is the green line, or will they have some deficits, which is the blue line, or will they have significant morbidity? We do know that there's a high prevalence of problems warranting intervention, from cognitive impairment, anxiety, and depression to physical debility and medication-related problems. You know, these patients are heavily sedated when they're in ECMO in the early part. Now, for long-term recovery, there is a study actually in the Oracle group wherein they have mentioned that the patients actually had no significant difference in terms of survival in patients who are those who are not on ECMO. But gotta notice, these patients were from March to May of 2020, when we didn't have as much ECMO patients then, and the run times were lower, and they have better survival at that time. So in conclusion, ECMO remains as a salvage therapy for most cases of ARDS after failure of optimized therapy like protective lung injury, proning, flow-length use, and treatment of etiology of ARDS. Since ECMO is a scarce resource, it is rationed even in ordinary times. So during the pandemic, resource allocation becomes even more important, especially with increasing number of patients and the shortage of intensive care capacity. So apart from meeting clinical criteria, capacity is an important element. So now the other factors to maximize benefit of ECMO treatment comes into play. Now, the demands of the healthcare system generate pandemic due to the acuity of its onset was very much anticipated, unbudgeted, and thus healthcare systems were understaffed, underspaced, and under-equipped. So ECMO may not be extensively used in such pandemic given the resource constraints and availability issues. We should be responsible enough to select our patients who we think would benefit the most from ECMO therapy. Now, I would like you to meet our ECMO team, and you will see in the four corners our ECMO surgeons who are cannulating, and then the rest of the team, ECMO specialists, PA, perfusionists, the nurses, and also the intensivists taking care of the patients. Thank you.
Thank you, Dr. Tuazon. This was a fascinating recap, and I was actively learning how we're describing about not only this, but the journey of ECMO.
Yes.
Before we go to questions, I would like to hear some real feedback from one of our top surgeons, Dr. Thomas MacGillivray and Dr. Suarez, who have been managing these patients, inserting them at all hours of the day and night. So, Dr. MacGillivray, you've listened to Dr. Tuazon. I think from the surgical perspective at both ends and management, we'd love to hear your thoughts.
Thank you very much. And first of all, I would say that that was an absolutely fabulous overview of, not just an overview of ECMO, but also a very deep dive into some of the data that we have and the lessons that we've learned. And I think we have learned a lot over the last year and a half taking care of patients with COVID. One of the things I've learned is we still have a lot to learn. My impression in caring for patients with COVID is I don't think that ECMO is actually, it's not a treatment for COVID. It is a way to stabilize people with COVID so that they can either recover because of the natural history of the disease, or they recover from the treatment from the disease. And we do know from years past that in patients who have terrible ARDS, some of our therapies with mechanical ventilation can contribute to their morbidity and their mortality. And I think that's the benefit from ECMO, is that it allows the patients who are going to get better the time to get better. The devil's in the details, how we choose and how we select the patients who we think are going to recover and get better. And at least from my perspective, I think we know a little bit more about that now than we did last March, but we're still learning and still trying to figure out how best to select these patients. And I know, along with Dr. Suarez, one of the things that's been very striking when we have done lung transplants on patients that have had COVID, patients who have been deemed to have unrecoverable lung function, I've been very impressed with the spectrum of the range of what these lungs look like. Some of the lungs have been absolutely destroyed. And certainly based on what I know about organ and organ function, those patients were absolutely never going to recover lung function. But there have been some other people where the lungs have not looked as bad. There's been some scarring, and that maybe there are some people who are in ECMO that we don't think are going to get better over time. Will perhaps get better enough to be able to get off ECMO.
All right, thank you, Dr. MacGillivray. Before I go to Dr. Suarez, I see quite a few questions coming up. And in case somebody has joined later on, I'd like to remind that you can text our question DEBAKEY to 37607, text in your message, or join by web, go to pollev.com and enter DEBAKEY and respond to activity. Dr. Suarez, I mean, you have been in forefront in a lot of, especially with the transplant patients along with Dr. MacGillivray. So we'd love to hear your insight in this last year and a half and the previous years.
For me, it's nothing I would ever anticipate. One of the questions we have up there is, do you think we will need more ECMO? And never in my life did I think we would be completely full of ECMO. We have so much need for ECMO that we couldn't fit the people in. I think at our highest volume, we had 10 people on at a time trying to push for more, and that's unprecedented. You know, the time I've been here, the last decade or so, we've never had that, even as a resident. And we've had that consistently, you know, with the different surges throughout this amount of time. How it's affected lung transplant, I completely concur with Dr. MacGillivray. The spectrum is fascinating. And when do you transplant? How long? That's a question we're all working for. The ones we've transplanted, I believe all of them have been on ECMO for over 2 months. There are reports of people being on for 3 months and recovering, maybe even a bit longer. At what point do you change? I do think the vast majority, I mean, basically all the ones that we have seen, even if they weren't a severe scarring, the lungs themselves were scarred. For me, what's fascinating is how adhesed it would be to the chest wall. These were the most difficult lung transplants that I've ever done in my life. So the severity of it is striking. For sure. And are we going to need more? Like Dr. Milga said, we're learning more and more, and there haven't been any trials that show that is an absolute decision to recommend it or not recommend it, but we all know people whose lives have been saved by ECMO.
Yeah.
There are people who I know would be dead if we had not put them on, and I think we all have that. How do we figure out which ones those are? And how do we figure out the ones where it's futile? That's something we're still learning. If we had so kind of a question I had for you, Divina, also is like, after learning all this, someone asked, do we need more ECMOs? If we had all the resources in the world, because that's what's limiting. The question was, do we need to ration ECMO? It's not a question anymore. It's a necessity. We have to ration it. It's not something we get to choose or not to choose. We don't have enough to use as we would like to. But if we had all the resources possible, we had 1 billion nurses and as many machines and surgeons put it in, would you be using it much more frequently? How much more frequently? What would your thoughts be? If resources weren't an issue at all, how would you see the change of ECMO, in usage? Ideally,
Ideally, if the patients meet criteria,
Yeah.
without thinking about resources, and if we can, we go to help the most patients when we can, go for the greater good, yes, I would put patients in ECMO if it had not been for resource constraints. Again, they have to meet criteria. We have to know that the ECMO will help them, because again, ECMO is a salvage therapy. It's not a treatment for the underlying problem.
I respectfully disagree. I think that even using our very selective criteria, more patients have died than have survived. And I think that it's not because the ECMO wasn't able to support them. It's because their disease, their COVID, and the diseases that have developed because of their COVID have resulted in their death, not the lack of ECMO. And so I think the disease, like most diseases, it's a spectrum as well. And I do think that the magic for us is going to be able to select the appropriate people to get the appropriate therapy. And I'm not, maybe, we have been in a situation, and I'd say the hardest, among the many hard things over the last year and a half, have been making a decision on an individual person to say, no, we're not going to be able to cannulate you for ECMO. And that, I think that we have all very carefully given extensive thoughtful deliberation for each individual person as to whether or not we thought this was the best way to take care of that person. And I think that we would have selected more people for ECMO just because we would want to do everything that we could to take care of as many people as we could. But I'm not sure it would have made a difference. I think that the problem with the disease is the disease, not with the ability to give enough ECMO.
So I'll pose a question on those lines of capacity and selection is how have you all dealt with actually patients whom you made the right decision of putting an ECMO in, and because of the care and the disease process, there's no exit strategy. They are not transplant, you know they're going to come out. How all three of you have managed to take patient off ECMO? Because people now Google everything and they feel that they can live for 2-3 years on ECMO, rightly or wrongly, but they're Googling this thing. So how all three of you have managed that? I'd like to ask that before I go to the question from the audience.
For me, to start with, that's the absolutely most challenging part of this process, I believe. When to say it's enough, and everyone has different limits. We've been trying to do it, obviously, like everything, through a consensus, trying to get a group decision, obviously, so people know these are never decisions made just by one person deciding this is right or wrong. This is one where we all decide, go over the data as best as we can and use our combined expertise and experience to say, at this point, we think it's futile. And having those conversations are difficult. And now with Dr. Tuazon has been great, as well as our ethicists, to be at the forefront to early on explain to the patients, to set the expectations of what can be expected, and if they don't, meet the goals we like of recovering on surgery, how we would expect to deal with the termination of the use of ECMO, and potentially, withdrawal of care. And it's with the volumes we've had, it's been hard on people. I mean, honestly, it's been very, very difficult. But it's what we're here for, and I'm proud to serve with a lot of people who are so thoughtful, and these are the people who I'd want making that decision if I was in this position.
I agree. I think that there's not a perfect science, but we use the science as best we can to make our decisions, and because of that, we don't make perfect decisions, but we do make the best decisions that we can. Not making a decision is a decision in of itself, and so that it's a lot easier to put somebody on ECMO than it is to try to take that patient off of ECMO, but if there was analysis that was done early on in New York about if the numbers kept going up, how quickly the hospitals and the intensive care units would get saturated, and then we wouldn't be able to take care of anybody. So as best we can with each individual patient, we don't make a decision just in the afternoon. I mean, I think that we have all been very careful to have a series of discussions over a series of time about individual patients as to when we think the likelihood that patient is going to, the reasonable likelihood that patient will recover before we've made the decision to take them off of ECMO. And I would say that in my 30 some odd years in medicine, this has been the most difficult part of this most difficult year.
And before I go to questions, as we all have lived through this thing, these are very difficult and challenging questions, situations, especially compounded by family not being at the bedside. I think that had made a lot more situation complicated and difficult. And so I think, and what I want to remind that all these decisions, and the best decision, not the perfect decisions, take a toll on all the healthcare team. Every one of us takes a toll for that. So let's start with some good questions which I see, which have been posted. So the first questions coming up is, how has HMH capacity, ECMO capacity changed over time to accommodate volumes during pandemic, and now especially with the recent spike in the Delta variant? What do you guys see? How many are you willing to do or not do? So go ahead, Dr. Tuazon.
Actually, our capacity did increase, just like in all hospitals, and like what I mentioned too in my slides earlier. The hospitals need to be able to gear up and gear down. So in terms of the capacity for ECMO, so we did in the first in July, and then in December, our capacity did increase dramatically compared to the amount of ECMOs we've actually had at a certain time since the whole years that I've been here. Now, in terms of whether that's something that we will continue to do, now it's going to be much more difficult because of the amount, of constraints that we have with, we have lost several nurses in our CVICU. We have lost several nurses in CICU, and also, of course, that affects the people who will take care of the patients on ECMO. So we have much more constraints now that we didn't have in July and December. So definitely we will probably, that's why we're not being able to do as much ECMOs now. So we have to go through the times. Like what I mentioned, we have to transition on different kinds of care depending on what we're dealt with at that time.
And exactly like you mentioned, Dr. MacGillivray may know more about this, but there are going to be spikes. We anticipate more need. The different challenge we have now that we didn't early on, we didn't know what to expect. So early on, we can put a hold on elective cases like bypasses or valve surgery, so we could make some room to give more resources to ECMO. That can't last indefinitely. We thought it was going to be a few weeks, a few months. You can't hold off someone's heart surgery for 2 years, which is where we're at right now. So balancing the real needs of those, that patient population with the acute needs of ECMO, that's the challenge that our administration and leaders like Dr. MacGillivray and Dr. Masud, you have to face. And how do you balance all the different needs? And I do not envy you at all, and I'm honored to see the challenges that you have all gone through to try balance that.
That's a great point, Eddie, and that as deadly as COVID has been, the leading cause of death last year was still heart disease. Mm-hmm. And so to Dr. Tuazon's point, we have to do the best we can to save as many people as we can, and we can't just focus all of our attention with all of our resources on one specific disease process, as bad as it is. We have to balance as best we can the ability to take care of as many people as we can with a number of different disease processes.
So again, it's not about a machine. It is really about the team to deliver the care. So I'll go to the next question, and again, this is Dr. Suarez or Dr. Tuazon. In your protocol for ECMO, one of the criteria on push was not only the vent setting, but prone positioning, and that they should attempt, conventional prone positioning, which has a pretty good evidence behind an ARDS patient. The question which is posed from the audience is there a plan to incorporate prone positioning for ARDS patient during the VV ECMO, not before only, because the Italians published a retrospective paper on this suggesting mortality different. So what are your thoughts on that?
We have started conversation on that. Even the French have much more experience on the proning patients during ECMO. But unfortunately at this time, our institution is not ready to prone patients on ECMO. We have recently just already done the proning of non-ECMO patients. We have memorized that. We have already done everything we can for that. But now the next step is, yes, we need to start planning for proning patients during ECMO, because as you know, there are a lot of factors with ECMO patients. We have to sedate them fully, paralyze them, and then even though during paralysis they actually they come out of it, and then they bleed, and then we have a lot of secretions that we need to take care of, and it's hard to take care of them when they're prone. So we need to balance all those. So we need to be able to prepare for those complications when we prone our patients during ECMO.
Yeah. Any treatment modality takes a lot of preparation. Even something that sounds as simple as proning takes a lot of effort. And it also, if there are the competing interesting treatments that go with it, such as early extubation. We found a mortality benefit. I think some people are starting to see mortality benefit with people who extubate and keep on ECMO. Taking away the mechanical ventilation seems to potentially be something that allows people to recover a little bit faster. Some people are even considering putting people on ECMO before ventilation. That's another question. If you had infinite resources, would that be a benefit? We don't know. To instead of doing a positive pressure system with high oxygen into the lungs, you put people on ECMO, would they recover more? Would the recovery be more favorable? There's still so much we're trying to learn, and we are trying to incorporate. We are constantly trying to incorporate different treatment modalities to improve, and proning is one of them. But there are multiples out there that we're looking at prospectively to try to incorporate.
Yeah, I think as we discussed earlier, with proning you have to sedate or paralyze, but we all know the longer duration of sedative medication and paralytic medication, you pay the price down the stream. Mm-hmm. If you extubate them, you still have a lot of them, perhaps you have less sedation, less paralytic. So it's sometimes we have to be mindful of the decision we make and the unintended consequences of those decisions. And we're still learning. I think that's the theme that we're learning. Let me ask this question, which is posed, is that what has been your experience with pregnant or expecting or about to deliver COVID patients who need ECMO? And you want to shed any light on that? Anybody?
There have been quite a few reports that being pregnant, the postpartum state is a risk factor for morbidity from COVID. We've had quite a few patients, more than we would anticipate, who needed ECMO who are postpartum. There are other places that have successfully placed pregnant COVID patients on ECMO and been on it for several weeks, if not months, and delivered full-term children. So it's something we haven't fortunately had to face yet, where we had to place someone on ECMO. But if there was needed, it would be discussion with all of us, obviously, but it would be something I would strongly consider, for sure.
I believe last year you did have some patients who were posted on ECMO and they were able to get babies delivered, and they end up going to rehab for M. So that is a modality which is potentially available in very rare but specific criteria. So let's go to more questions. The very big question which has come up with, there was a very nice New York Times article also done in about many centers of ECMO across the country, and our own Dr. Suarez were very nicely mentioned. He gave his opinion. But the question which has come up very interestingly, which is being posed, which was, I think, Dr. Tuazon also alluded it. Do you think ECMO should be allocated just like the organ transplant? There should be a registry, there should be a state level or a city level, like UNOS and others. Should they be allocated? Because what I'm hearing from all three of you is very resource intensive, very well-defined patient population, very expensive, short-term and long-term. Should these things be much more an organized fashion, and is the time right now? Because we have never been in this situation. So I'd like to hear from all three of you.
Actually, in Paris, they kind of almost did that, right? The study that they showed is like they actually incorporated all the ECMO centers in their city, and then they talked about they decide which one goes, who goes on ECMO. It goes to a particular hospital which is nearest to the patient. So actually, they kind of did that already. We started, we were collaborating with the other hospitals here in the medical center early on. I think you were having discussion, but not recently. But I'm not sure about really allocating them like an organ transplant, like but I think it's mainly collaboration with the other ECMO centers, and talk to them, if they have the capacity and there's this pregnant woman who's needing the ECMO, probably they can accommodate the patient if we don't have the capacity, more of that.
Dr. MacGillivray?
Yeah, I think ELSO, in their wisdom, initially made the recommendation that there shouldn't be any generalized statements of how to use ECMO for this disease. And I think they understood and understand that resources are very dependent upon individual institutions, localities, and regions. And I think that the decisions are best made when you factor all of those in. I think that individual hospitals we have a benefit of having a tremendous ICU, tremendous intensivists, wonderfully trained nurses. We have ECMO specialists, surgeons, perfusionists, and that gives us the ability to care for many people on ECMO, and we're still limited. I think that other hospitals in the region, other hospitals in smaller metropolitan or local areas don't have that ability. The flip side is if you try to make generalized statements about who should do what, when, under each circumstance, I think that would be more limiting than it would be able to provide more care, is my sense.
I like the idea of sharing resources. I mean, it makes common sense, but the difference between organ allocation and ECMO allocation is that you're allocating patients, not just the resources. So if someone needs ECMO, you decide to send them to hospital A, B, C, or D. The difference is that with transplant, each hospital is allowed to have their own separate patient selection. A person who's an appropriate transplant candidate for Duke may not be appropriate transplant candidate for another hospital. Same with ECMO. If someone deems a ECMO candidate in hospital A, if you send them over to hospital B, they may see them and say, hey, this isn't someone we'd put on ECMO. So it gets a little bit more difficult that way because you're not allocating ECMO, you're allocating the patients who need ECMO, which is a different beast.
So one last question before the thing is, and Dr. Tuazon and Dr. Suarez, it's two questions. How have been your outcomes compared to ELSO, HMH ECMO outcomes compared to ELSO?
We're actually much better compared to ELSO because our overall, for COVID, ELSO is 48%, ours is 35%.
Huh.
Even for our overall ECMOs, ours is 32% and ELSO is 49%. So I think so ours is much better.
Okay, so with
mortality.
your experience in talking to ELSO and everything, are all ECMOs concentrated in one ICU location, VV, VA, COVID, or typically these are more than one ICU, these ECMOs are there? Is it one every, or like an ECMO 20-bed ECMO unit, or they're more than one location, whether VA, VV, COVID, non-COVID, pre-transplant, post-transplant? What are your thoughts?
Different institutions have found different models that have worked for them, and it is very, very specific, I think, to institution. The training of the perfusionist, the amount of perfusionists, the nursing training, the specialists. So we visited, obviously, Columbia has a great program over there. They have ECMO in multiple different units. For us, originally we had it all in our CVICU unit, and as we all know, we've tried to do different models to try to expand it to different units, to try to segregate units, but I don't think there's one answer fits all, for sure. It's definitely institution to institution.
ECMO isn't a drug. It's not even an intervention. I mean, ECMO is a process of care, and it requires a system that allows you to provide the best care you can. And so I think that as Dr. Suarez said, I think how those resources and that system varies from center to center.
Well, with that, I'd like to thank Dr. Tuazon, Dr. MacGillivray, Dr. Suarez for an excellent, in-depth, and very thoughtful discussion on a very complex situation. This is very valuable. My name is Dr. Faisal Masud. I oversee the Critical Care Center, Houston Methodist. And on behalf of all of us, I'd like to thank all of you and thank you for any question. And I hope you all have a great day.